Protruding ears, or prominent ears, or promenoris, are defined as the abnormal protrusion of the ears from the head. It has been estimated that approximately 5% of the population are affected by this condition to varying degrees. The prominent ear is the most common external ear deformity. It is inherited as an autosomal dominant trait and is commonly caused by a combination of two defects: underdevelopment of antihelical folding and overdevelopment of the conchal wall. After a recent classification of congenital auricular anomalies, prominent ears are regarded as a deformational auricular anomaly, in which the deformity occurs in utero after the 10th week or even postnatally. Despite its benign physiologic consequences, numerous studies attest to the psychological distress, emotional trauma, and behavioral problems this deformity can inflict on children. In childhood, they become a source of teasing from other children. In adolescence, the aesthetic deformity can worsen this period of great uncertainty and change, and in adulthood, the correction of protruding ears could represent the trauma of an uncomfortable childhood or adolescence. Innumerable surgical techniques have been proposed for treating prominent ears. Over 200 techniques have been described for the surgical correction of prominent ears, suggesting that no single, best, technique exists and that techniques and modifications will continue to evolve. This reflects the need for a single technique that is simple, adaptable for correcting all deformities, successful, and has a low complication rate. History. Not earlier than in the end of the 19th century, reports on surgical techniques used to pin down protruding ears for cosmetic reasons were published. Diefenbach, 1845, is credited with the first otoplasty for the protruding ear, post-traumatic. He used post-auricular skin excision with conchomastoidal fixation. In fact, the first recorded otoplasty for aesthetic purposes in medical literature was in 1881. Edward Talbot Ely, an American surgeon known as the father of aesthetic otoplasty, performed the surgery on a 12-year-old boy who suffered from psychological distress due to his prominent ears. After several efforts and revisions by Keene, Monks, Cottrell, Moraes-Tin, and Gersony, Luckett introduced the important concept of restoration of the antihelical fold. Luckett corrected this deformity by using a cartilage-breaking technique consisting of skin and cartilage excision along the length of the antihelical fold combined with horizontal mattress sutures. Becker, in 1952, introduced the concept of conical antihelical tubing using a combination of cartilage incisions and suture techniques in an effort to soften the contour of the corrected prominent ear. This technique was later refined by Converse in 1955 and then Converse and Woodsmith in 1963. Mustard's 1963 approach to the creation of antihelical tubing was to use permanent conchoscaphal mattress sutures. The work of Gibson and Davis, 1958, on the ability of injured cartilage to warp away from the injured surface, the balance beam theory of cartilage behavior, led to the Chongchet, 1963, and Stenstrom, 1963, techniques. Chongchet's technique used sharp scoring of the lateral scaphoid cartilage, with a scalpel, to form an antihelix. Stenstrom, in contrast, used a rasp to blindly score the antihelix. Conchal reduction has been performed using various techniques. However, the use of conchomastoidal suturing was popularized by Furness and later modified by Spira et al. Ear development. The external ear also forms from tissues of the first and second pharyngeal arches. 6 tissue elevations termed auricular hillock, hillocks of His, become apparent in the 5th week of embryonic development. 3 form the first arch and 3 form the second arch. Between the 6th and 9th weeks of development, the hillocks enlarge, differentiate and fuse to form the structures of the outer ear. The developing external ears are initially more caudal than the lower jaw. Growth of the lower jaw places the external ear in a relatively higher and more vertical orientation. The first branchial arch gives rise to hillocks of his 1 to 3, 1, tragus, 2, helical cruce, 3, helix, and the second branchial arch gives rise to hillock of his 4 to 6, 4, antihelical cruce, 5, antihelix, 6, lobule and antitragus. In summary, hillock 1 will become the tragus. Hillock 2 will become the helical cruce. Hillock 3, the ascending helix. Hillock 4, the upper helix, scapha, and antihelix. Hillock 5, the descending helix, middle scapha, and antihelix, and hillock 6, the inferior helix and antitragus. The proposed theories on the embryological development of the human auricle. A. Lateral view of the original embryo in Carnegie stage, 42 to 44 days. B. Close-up of the auricular hillix as described by His in 1885. C. Simplified version of the auricular hillix. Numbers 1 to 3 have been described to be of the first pharyngeal arch origin and 4 to 6 as the second pharyngeal arch derivative. D. The proposed theories of the embryological development of the human auricle as described by several authors. The fate of the hillix as described by the authors are indicated by numbers 1 to 6. The first arrow represents the dorsal rotation of the second pharyngeal arch as described by His in 1885. The second arrow represents the ventral rotation of the first pharyngeal arch as described by Wood-Jones and Eichhorn in 1934. The ear attains approximately 85% of its adult size by age 3 years. Ear width reaches its mature size in boys at 7 years and in girls at 6 years. Ear length matures in boys at 13 years and in girls at 12. Human ear grows 0.25 mm/year throughout the entire lifetime. The older the person becomes, the stiffer and more calcified the cartilage. This progression has an effect on the techniques used to correct the prominent ear, cartilage molding versus cartilage breaking. Ear anatomy. The ear is a complex structure composed of elastic cartilage and skin. The three-dimensional topography of the external ear with its many elevations, depressions, involutions, and folds is reflective of the underlying cartilaginous structure. The important surface features of the auricle are: the helix is the peripherally located rim of the auricle. It extends anteriorly to form the root of the helix, or cruce of the helix, oriented horizontally above the external acoustic meatus. The antihelix begins at the antitragus and runs anterior and parallel to the helix, initially as a single prominence. In its superiormost extent, the antihelix splits into superior, posterior, and inferior, anterior, crura, and the depression created by this division is known as the triangular fossa. The deep concave furrow in between the helix and the antihelix is known as the scapha or scaphoid fossa. Immediately inferior to the root of the helix is the tragus. The space between the cruce of the helix and the tragus is the anterior incisure. The antitragus is postero-inferior to the tragus, and the space between the tragus and antitragus is known as the intertragal incisure. The conchus is a cavity posterior to the external auditory meatus and surrounded by the antihelical fold. The cruce of the helix divides the conchal cavity into the cymba, superior, and cavum, inferior, conchus, which is approximately 8 mm deeper than the tragus and antitragus. Below the antitragus is the lobule, which is devoid of cartilage, composed entirely of areolar connective tissue and fat, and marks an important landmark for the inferior auricle. Arterial blood supply. The anterior blood supply comes from the superficial temporal artery. The posterior auricle is fed by the posterior auricular artery. There is a supplemental blood supply from branches of the occipital artery. The superficial temporal artery and the posterior auricular artery communicate via the helical arcade. This arcade is the basis for single pedicle reimplantation of total avulsion of the auricle. Nerve distribution of the external ear. The great auricular nerve, cervical plexus, C2, C3, supplies the descending helix and the lobule. The auricular branch of the vagus nerve supplies the concus. The auriculotemporal nerve, trigeminal nerve, supplies the ascending helix and superior helix as far as Darwin's tubercle, the triangular fossa, the scapha, the antitragus, and the antihelix including the antihelical wall. Motor innervation to muscles of the external ear is supplied by branches of the facial nerve, cranial nerve 7. Lymphatic drainage of the auricle. Coursing in the auricle's subcutaneous fat, the lymphatic vessels in the region coalesce into 4 groups of collecting branches. The anterior branch represents the convergence of lymph vessels from most of the auricle's lateral surface, and drains into the preauricular lymph nodes. The superior branches are made up of lymph vessels that arise in the superior helix and course along the posterior aspect of the auricle to the infraauricular lymph node. Arising from the scaphoid fossa, the middle branches course over the helical rim, to the auricle's posterior aspect, then drain into the infraauricular lymph node. Finally, the inferior branches arise from the lobule and course down to drain into the infraauricular lymph nodes. 4 groups of lymph-collecting vessels were found in the external ear: the anterior, superior, middle, and inferior, lobule, branches. Anterior and posterior diagrams show the lymphatic drainage of the external ear. Ligaments and muscles. Auricular muscles can be classified as either extrinsic or intrinsic. Extrinsic muscles of the ear originate at a location other than the auricle itself. Intrinsic muscles, on the other hand, both originate from an insert on the auricle. There are 3 extrinsic auricular muscles: the anterior, posterior, and superior muscles. The intrinsic auricular muscles, of which there are 6, determine the auricle's cartilaginous topography. This group includes the major helical, minor helical, tragal, and antitragal muscles on the auricle's anterior surface. Posteriorly, one finds the auricular oblique and transverse muscles. Auricular muscles of the ear. Source: Standring S. Gray's Anatomy, the anatomical basis of clinical practice. Ear anthropometry.